اوكي، بسم الله الرحمن الرحيم. ده الويبينار بتاع الهيدن دانيك يونت في معهد الأورام، جامعة القاهرة. النهاردة هيكون على الأورال كافيتي والأوروفانكس. هنبتدي دكتورة فاطمة هتقول لنا الأناتومي زي ما احنا متعودين، الأناتومي وبعدين الديفرنشال دايجنوزيس بتاع الليجن وبعدين الباثولوجي وهكذا. بسم الله، هنبتدي الأناتومي.
Welcome everyone. In this session, we'll walk through the etiological anatomy of two connected territories, the oral cavity and the pharynx. So we build the region by region, so let's start by going all the way out. Before narrowing in, let's place all these four major regions together. The nasal cavity, which is the most proximal respiratory structure, the oral cavity, the most proximal aerodigestive structure, the pharynx is that shared muscular tube that connects both the esophagus and the larynx that branches off to the trachea and the lungs. So today's talk is in the oral cavity and the pharynx. So let's fix that framework in place before we touch any detailed anatomy. The oral cavity, we were talking about the floor of the mouth. The pharynx will handle the oropharynx and hypopharynx, as we have talked in the previous lectures about the nasopharynx. So let's do it. Quickly, the imaging modalities. We have the CT, which is the everyday staging workhouse. It is best for the cortical bone, cartilage, and nose, and it catches the chest in the same pass. So it is usually the first study. And a Valsalva maneuver would help to extend the recesses. As for MRI, it is the problem solver for the deep soft tissue, the depth of invasion, the marrow, and the perineal spread. And with the diffusion that separates tumor from post-treatment changes, as we'll discuss later. And the BET CT would cover the wider view, distant metastasis, synchronous second primary, and recurrence versus the treatment change on surveillance. Hold that division in mind. And now let's look how we actually acquire each one. Here is the CT technique. The patient lies supine with the neck slightly hyperextended, and we start with a lateral scanogram to plan the slices. We take 2 to 3 millimeter sections, angled parallel to the lower edge of the mandible, and key for our region, which is the key for our region. And that coverage runs from the hard palate down to the GI bone. That's the field of view boxed on that scanogram. Quiet breathing keeps motion down, and we give IV contrast as well. Everything read on a soft tissue window with a bone window added when we are hunting for cartilage invasion, and the data can be formatted into 2D, 3D, or virtual endoscopy. As for the MRI technique, we use a dedicated head and neck coil, and the main enemy here is the motion, swallowing and respiration, so patient cooperation do matters. Sequences are sagittal, axial T1, axial T2, and probably density with fat suppression, and fat suppressed T1 before and after contrast. With the technique settled, let's begin the anatomy itself, starting with the oral cavity. Here is the oral cavity. It begins anteriorly at the lips and posteriorly at the circumvallate papilla and the posterior tonsillar pearls. Those papilla are hard to see on MRI, so in practice we use the hard palate and soft palate junction at the posterior landmark. The roof is the palate, the floor is the mouth, and the lateral walls are the cheeks. So summarizing those borders, anteriorly the lips and cheeks, superiorly the hard palate, inferiorly the floor of the mouth, and posteriorly, as seen here, an imaginary line dropping from the hard and soft palate junction down to the level of the hyoid bone. That posterior line really matters because it's the exact handoff point between the oral cavity and the oropharynx. And that raises the obvious question: why does separating the oral cavity from the oropharynx matter so much? Because the treatment diverse. Oral cavity squamous cell carcinoma is generally surgery first. Oropharyngeal squamous cell carcinoma often chemoradiation first. So different treatment, different prognosis. So getting the subsite right and imaging is what sends the patient down to the correct pathway. And that makes this the single most important boundary call you will make on these studies. So here are the contents of the oral cavity. We have the lips, the buccal mucosa, the alveolar ridge, the hard palate, the oral tongue, the floor of the mouth, the retromolar trigone. And here we have to notice that the vestibule is that slit-like space outside the teeth between the lips and cheeks and the dental arch, while the oral cavity proper itself is everything medial to the teeth. So we have the buccal mucosa, the alveolar ridge, the hard palate, the oral tongue, the floor of the mouth, and the retromolar trigone. So worth keeping the two separate when you describe where a lesion sits. The oral cavity proper is thus made of 7 subsets: lips, oral tongue, floor of the mouth, retromolar trigone, the gingiva, the buccal mucosa, and the hard palate. We have to recognize all these 7 subsets by name, but we are going to go deep on just one, the floor of the mouth. Here is the definition worth memorizing. The floor of the mouth is that part of the oral cavity beneath the tongue. It's bounded above by the oral mucosa surface and below by the mylohyoid muscular slinge. That clinical photo on the right is exactly that view, looking straight up into the mouth. Before we dissect that floor of the mouth, here is the roadmap. 4 things to cover here: the muscular diaphragm that forms the floor, the salivary glands sitting within, the sublingual space, the vessels and nerves running through. So let's start with the diaphragm and specifically its workhouse, the mylohyoid muscle. A quick step back to the name, the whole diaphragm. 3 muscles build it up. The mylohyoid, the that main slinge, the genohyoid sit just above and medial to it, and the anterior body of the gastric muscles run alongside. Together, they form the partition that separates the sublingual space from the submandibular space below, with the mylohyoid slinge cupping the tongue base and the genohyoid complex forming the midline pillar. Now with the muscle that defines the floor, the mylohyoid, which is the workhouse here, it originates from the midline fibrous trackway running from the mandibular symphysis back to the body of the hyoid, as seen in that diagram on the left. And it inserts broadly along the mylohyoid line on the lingual cortex of the mandible, as seen in that diagram on the right. Its posterolateral edge, though, has no attachment. It floats free, and that free edge matters. Here is the pearl. A lesion that pushes the mylohyoid downwards is arising surely from the floor of the mouth or tongue. A lesion that pushes it upwards is coming from the submandibular space below. So let's follow the mylohyoid, that muscle in blue, across these consecutive colon slices from front to back. And we have to notice here that the free edge of the mylohyoid muscle in the axial view of the MRI on the right, we can see that the free edge, okay, of the mylohyoid connects the 2 spaces. The space denoted by the star-like shape is the sublingual space, okay, and the submandibular space in the that is colored by orange. And we have to mention that this is the main route by which a floor of the mouth, tumor, or infection spread from one space to another. Tracing those same landmarks on this coronal view, sitting along the posterior border of the mylohyoid are the submandibular glands, drained by the Barrett Wharton duct, noted by the initial letters WD in the exit image on the right. And on MRI, they are relatively hypotense on T1 and hyperintense on T2 and STIR. The duct pierced the undersurface of the mylohyoid to open into the mouth beneath the tongue. So a floor of mouth or tongue root tumor can obstruct them and cause visible duct dilatation. The sublingual glands sit more anteriorly against the inner mandible. Within the sublingual space, we are about, and that is the sublingual space we are about to explore. So let's take a quick breath and see where we are now. Remember, the floor of the mouth has 4 parts. We have now covered 2 of them, the muscular diaphragm, the salivary glands. That leaves the sublingual space, which we will take next, and then the vessels, nerves that run through it. So the sublingual space itself, the fat and gland-containing compartment of the floor of the mouth sitting above the mylohyoid bounded medially by genoglossus and genohyoid, it holds the sublingual glands, which drain through short ducts into the mouth. And what runs through that space is exactly what a floor of the mouth tumor threatens as it spreads. Sublingual glands, the Wharton's duct heading to the submandibular gland, the lingual nerve carrying sensation from the trigeminal, and the hypoglossal nerve, that cranial nerve holding innervation for the tongue motor function, and the lingual artery and vein. So think of it as the neurovascular corridor of the floor of the mouth. One more spread route to flag. The floor of the mouth lesions can extend into the mandibular canal, which carries the inferior alveolar nerve. That canal starts at the inner cortex near the mandibular angle, the same spot targeted for the inferior alveolar nerve blocks, and that runs through the lower mandibular body and exits at the mental foramen on the anterior outer cortex. The perennial spread along that route is something to look for specifically when handling floor of mouth lesions. So that completes the floor of the mouth. Now we shift from the oral cavity into the pharynx. Back with the technique, here we need to acquire both the axial and coronal images, whether by CT or by MRI. On CT, the axial images, you would start at the inferior border of the mandible and proceed upwards until you reach the skull base. Then, in the coronal plane, you cover the area of the pharynx from the spine posteriorly, moving anteriorly until you reach roughly the mid part of the maxillary sinus. The scanning intervals are every 5 millimeters, and you should obtain post-axial and coronal scans. In many cases, you also need to inject intravenous contrast. In MRI, the core sequence are T1 before and after contrast, fat-saturated T2, and STIR in post-axial and coronal planes with the gadolinium agent. The non-fat-saturated pre-contrast T1 is what shows the normal muscle and fat planes, the planes that get obliterated by any invasive tumor or infection, while the STIR is the best for picking up abnormal edema. So in short, always T1 pre and post plus T2 and STIR in multiple planes. In these 2 sagittal planes, T1 on the left, CT on the right, show how the pharynx divides along its length, and that division is the roadmap for the rest of the talk. The pharynx is divided into 3 levels by 2 bony and soft tissue landmarks visible on the sagittal image. The soft palate separates the nasopharynx from the oropharynx, and the hyoid at that level of the epiglottic tip separate the oropharynx from the hypopharynx. While the nasopharynx begins at the skull base, the hypopharynx ends at the lower border of the cricoid cartilage, continuing at the cervical esophagus. And a small note here is that the epiglottis itself is a part of the hypopharynx, not the oropharynx. Starting with the oropharynx that sits directly behind the oral cavity. Its anterior border is the hard palate, two soft palate junction. Superiorly, it's that imaginary line we have talked before, extending back from the palate, and inferiorly, it reaches down to the level of the hyoid bone. Above, it's the nasopharynx, below it, the hypopharynx, and the larynx. So concerning the borders, superiorly, the oropharynx, we have that elevated soft palate. Posteriorly and laterally, the pharyngeal walls, and inferiorly, the epiglottis at the level of the vallicula. So, oropharynx, four subsides to know: tongue base, tonsillar region, soft palate, and the posterior wall. Deep to that oropharyngeal mucosa, which is continuous with that mucosa of the oral cavity, sit the pharyngeal constrictor muscles. Along the lateral and posterior walls, you will find the superior and middle constrictor. The superior arises from the pterygomandibular graphene and sweeps back to insert on the midline medial graphene. And the middle constrictor muscle arises mainly from the hyoid and overlaps it, while the inferior constrictor belongs to the hypopharynx. So we'll meet that one later. So done with the posterior wall. Now to the tonsillar region. The tonsillar region, we have two paired mucosal arches sit along the upper oropharynx. The anterior arch formed by the ballatoglossus, the posterior pillar, which is made by the ballatopharyngeus muscles. Between them is the tonsillar fossa, here noted by the that star-like shape, holding the palatine tonsils in, which is a common site for the oropharyngeal carcinoma. The inguinal tonsils sit further back along the tongue base and can extend down toward the vallicula. The vallicula is that paired recesses appear on the image on the high left, and that vallicula are that paired recesses divided at the midline by the glossoepiglottic fold, which extends from the tongue base anteriorly to the epiglottis posteriorly. The lingual tonsils, as noted by those white small arrows, may encroach upon the vallicula partially, but here, this is considered to be normal, but here is the pearl. A normal lingual tonsil should not extend past to the anterior margin of the vallicula. If the tonsillar signet or density fills the floor or posterior border of the vallicula, stop calling that normal variant, and that needs to be treated with suspicion and biopsied. So again, as you can see in the picture on that axial MRI image on the right, the blue marks for the anterior tonsillar pillar, the balatoglossus, the yellow dots marks for the ballatopharyngeus muscles, the posterior tonsillar pillar, and between them, so they make like x-axis originating from the uvula, and between this X shape is that star referring to the tonsillar fossa or the palatine tonsils themselves. And the red dots marks the constrictor muscles, and I think here that cut it's marking the superior constrictor muscle. So we arrive at the hypopharynx now, the inferior continuation of the same pharyngeal tube suspended from the skull base. So passing quickly through these sections from the level of the hyoid bone to the cricoid. The normal larynx, hypopharynx anatomy, the first column represented by these axial CT cuts. Second column is the MRI T2 weighted images, then MRI T1 weighted. The first row, At that level of the hyoid bone shows the free margins of the epiglottis, denoted by that arrow, with the mucosal glossoepiglottic fold in the midline and the bird pharyngeal epiglottic folds laterally demarcating the bird vallicula with the star-like shape. Second row, at that level of the fixed epiglottis showing the piriform sinuses with that white dot, bounded medially by the aeroepiglottic folds, annotated with that arrow or less than mark, and posteriorly by the posterior hypopharyngeal wall. So note the preserved fat-containing periepiglottic spaces merging with the paraepiglottic spaces on the MRI in that second row. While the third row is the level of the superior process at the arytenoid cartilage, showing the false chords. It's marked by that short arrow, and the paraepiglottic space with the long arrow. The lateral boundary of the piriform sinus, we previously said that they mark it with that white dot. At this level is formed by the thyroid cartilage. The lateral border of the piriform sinus at the third row is formed here by the thyroid cartilage. Okay. The fourth row, this shows the level of the true vocal cords, which attach to the arytenoid. That long arrow points to the arytenoid. Note the cricoarytenoid junction and the thyroarytenoid muscle. The thyroarytenoid muscle here, they put a star-like shape on it. And that muscle indicates the level of the glottis. Also note the normal thyroarytenoid gap. That short arrow points to the thyroarytenoid gap, okay? And the minimal soft tissue here is about 1 to 2 millimeters at the anterior and posterior commissure. And this is important because here at the bottom row, at the level of the subglottis, the cricoid ring, here we can see that the soft tissue in the inner aspect of the cricoid cartilage, there is absence of that soft tissue. So these 2 millimeters is now absent at that level. Also note the apposition of the post-cricoid mucosa here pointed by that short arrow. They are opposed to the posterior hypopharyngeal wall, marked by the long arrow. So the short and long arrow here points to the two mucosal surfaces opposing each other, the postcricoid mucosa and the posterior hypopharyngeal walls. So with that level by level overview in mind, let's break the hypopharynx into its main subsides and borders. The borders, we have superiorly the epiglottis, and inferiorly the cricoid, posteriorly the posterior wall, the posterior pharyngeal wall, and laterally the piriform recesses on both sides, and anteriorly the laryngeal inlets. Now we can say that the hypopharynx has 3 components: piriform sinuses, posterior wall, and postcricoid region. Let's talk about each one. Looking closer at the piriform sinus, its anterior wall is the back of the aeroepiglottic folds, and its lateral wall hugs the inner surface of the posterior third of the thyroid lamina. Inferiorly, it tapers as we go down to until reaching just an apex, which usually sits right at the plane of the vocal cord, like we see in the axial cut named F. Just the piriform sinus become just an apex that sits right at the plane of the vocal cord. The posterior and lateral walls of the hypopharynx like before we talked about within the oropharynx is defined deeply by the constrictor muscles, and here the inferior one that inserts laterally onto the outer surface of the posterior third of the thyroid lamina. Finally, the post-cricoid region is that the anterior mucosa lying immediately behind the cricoid cartilage. And it's a distinct oncological subsite. So name it specifically when you report. So let's back it up. The subsites, which is the main important thing here to differentiate, because as we have discussed, the subsites of the oropharynx, the hypopharynx, and the throat of the mouth, the subsite specific differences are critical because they directly influence TNM staging, treatment planning, surgeries versus chemotherapy, and as well as the prognosis. For example, the subsites of the hypopharynx. The piriform sinus as a subsite is the most common hypopharyngeal cancer site. Early spread to the paraglottic space and levels 2 to 4 cervical lymph nodes. This is characteristic for that subset. While the posterior pharyngeal wall, it tends to spread submucosally and across the midline. The prevertebral fascia invasion indicates advanced, often unresectable disease, while the last subsite, the post-cricoid region, frequently extends into the cervical esophagus and is associated with late presentation and a less, though favorable prognosis. And here, the MRI, as we have seen, is superior for evaluating the soft tissue extension, prevertebral invasion, and the bone marrow involvement, as we've said earlier, while the CD is superior for detecting the cortical destruction and assessing the cortical bone. So again, subsite is specific differences do matters because they influence the staging, the treatment, and as well as the prognosis. That's all for now. Thank you.
اوكي تمام، شكرا جزيلا يا فاطمة. المحاضرة هايلة وبصراحة سو ديتيلد يعني. ف ما شاء الله المحاضرة هايلة جدا. طيب احنا كده فاضل لنا 10 دقايق في اللينك ده، اعتقد نخرج وندخل تاني. معلش الصوت بعيد شوية. anyway المحاضرة متسجلة، وإن شاء الله بإذن الله هتبقى متاحة أحسن في التسجيل يعني. طيب احنا هنخرج وندخل تاني عشان نشوف المحاضرة اللي بعد كده، اللي هي الديفرنشال دياجنوزيس للأورال كافيتي والأوروفارينجيال ليجنز، علشان ما عادش إلا 10 دقايق، فمش عاوزين ندخل في يعني الميتنج يقطع علينا في النص، فهستأذنكم هنخرج وندخل تاني على طول.